Thank you, madam. Thank you, madam. Good morning. Good morning, sir. Good morning, audience. So today's case is about the VKH, Vogt-Kayana-Harada syndrome, a case presentation. So presenting illness, patient 43 years old, female patient came to our OPD with chief complaint of pain. Why the slides are, now. And blurring of vision since last 3 days. She complained of pain, redness in both eyes, which was sudden in onset and progressive in nature. The pain was dull aching, non-radiating, continuous in nature, and was associated with blurring of vision. So there was no aggravation or relieving factors, no difficulty in hearing. Then negative history we have taken, so no history of any discharge, no history of headache, floaters, trauma, fever, low grade backache, joint pain, and any skin problems or any mouth ulcers and so. So past history, no past history in similar complaints. There was no any history of any surgery done in the past. Patient was non-hypertensive, non-diabetic, or any other systemic factors. Family history was also not very contributory. So this was the clinical assessment in which the visual acuity in the right eye was reduced to finger counting at 1 meter, where left eye it was reduced to 6/18. The orbital margins were intact, the eyebrows were normal, eyelashes and the lid conditions were normal, ocular alignment was also normal. The conjunctiva in the right eye, they had dilated congested vessels, they arranged in radially around the limbus, circumcorneal congestion was present. In cornea, 15 to 20 fresh small size non-confluent non-pigmented keratic precipitates KPs, they were seen on the inferior aspect of the corneal endothelium in the base of the in its typical pattern. Then the anterior chamber was positive 3 for the flare and the cells. And the left eye again also had the circumcorneal congestion, and there were again KPs 15 to the 10, a little bit less in the number, and there was a flare and a little bit flare in the left eye. So this was the clinical picture of the right eye and the picture of the left eye, showing the keratic precipitates and the flare and the cells. Then the iris, normal in the right eye it was normal in color and pattern, pupillary reactions were normal to light. Then the lens was clear and the anterior vitreous phase was quiet. In the left eye also we had a similar findings. Fundus evaluation in the right eye, the media were clear, disc and the vessels seen, margins were well defined, there is 0.3 cupping, normal neuroretinal rim, foveal reflex absent, macular edema was there, multiple subretinal fluid pockets at the macula were seen. In the left eye the media were clear, disc and the vessels seen, margins were well defined, and the foveal reflex was absent, and again there was a similar sort of picture in the left eye showing the macular edema, multiple subretinal fluids and the pockets at the macula. So this was the fundus picture showing the macular edema in the both eyes. Then the certain tests were done. ESR was raised in this case, serum creatinine was 0.7, and chest X-ray, TB Gold test and Montauk salt tests were done and they were within normal limits. So this was the B scan of in the right eye and the left eye, and not much of findings in the B scan. The RCS complex thickening, vitreous cavity shows incomplete PVD and vitreous opacities. So query there was a sort of a serous RD sort of a picture. Then this was the finding of the OCT in the right eye and the left eye. So there was definitely the macular edema was more prominent in the right eye as compared to the left eye, which was done in the OCT. Then the FFA was done, multiple hyperfluorescence foci, increase in the size and intensity seen with hyperfluorescent disc, that is starry sky appearance was seen in both eyes. Then the management was done with the IV methylprednisolone, 1 gram of 3 doses, topical steroids, and oral steroids with 50 milligrams was gradually tapered in this case. So this was the post-op picture, and the resolved dull and Fuchs spots were seen in the both eyes. And this was the right eye and left eye picture. So, and resolved subretinal fluid after treating the case on the OCT. So
can we go back to the original fundus picture?
Yeah.
So what is dull and Fuchs here?
In dull and Fuchs in the near fovea, those spots they were there, no? So that was detected, yeah. So
Fuchs is classically
I know.
described in the periphery.
I know. Less likely that in the center of the, yeah.
These look like more like active lesions of choroiditis,
Correct.
which is causing the exudation.
Correct.
And they have resolved rapidly.
Yeah.
Dull and Fuchs does not resolve rapidly also.
Yes, madam.
Chronicity,
Yes.
feature of chronicity.
Correct. Yes.
Very good documentation documentation.
Thank you, madam. Thank you. And again, as no VKH is a big diagnosis. We have a problem. Confusion is there, and lot of treatment modalities. Again, we have multiple modalities of treatment, and it is quite difficult also for resolution.
So
Yes.
this, you have based on now your clinical findings.
Yeah. Yeah.
Then what would be the differential diagnosis? How to confirm that this is a case of VKH?
No, VKH, the clinical findings at the KPs were there. So it was normally VKH is a pan-uveitis. So we should get anterior segment findings plus posterior segment findings. So anterior segment findings where the flares was there, cells was there, then KPs were there, little bit big size KPs were also there, and posterior segment finding was in the macula. Of course, there should have been a more severe sort of a vitritis, and so in primary this thing that presentation was not there.
If you can go to the OCT.
Yeah.
You have a very beautiful image of maxillary layered detachment.
Yeah.
Classically
Yeah.
described.
Describe. Yes, sir.
That is a very good finding in this particular.
Can you explain the bacillary?
We can see, just above the RP, you can see some tissue is still there. So basically, the fluid accumulation is not a typical NOC, it is above ELM.
Yes.
So that is, the splitting is actually happening intraretinally. To it, in the first glance, it appears like a NOC, but it is actually a bacillary layered detachment.
Yes, sir. So that is quite typical, and what you have highlighted, that is very important finding. Not in all cases we may get such sort of a finding, but then clinically correlating, and then OCT picture and the symptom history wise.
FFA is also very classic for
Yeah.
VKH.
Yes, madam.
Pinpoint hyperplasia.
Yes, madam. So that is a typical of that.
So
Yes.
when you say VKH, would you not plan a long-term treatment rather
Yeah.
than just suddenly stop the steroids?
No. Yeah. We have to plan long term, because remissions and then again relapses are more common in this condition.
You
Yeah.
are not kept him on any immunosuppression.
No, not on immunosuppression, because the condition was resolved. The patient is still coming, and then we are managing it. So right now we don't want to load him excess with steroids. So, but again, if some signs they occur, definitely we'll like to put him on the the immunosuppressives. Yeah. Thank you, sir. Thank you, madam. Thank you, sir. Thank you. Yes, thank you, madam. Thank you, sir.
Dr. Utkarsh is there?
So I invite Dr. Utkarsh Ruchi to present his case on diagnostic challenges and management of bilateral acute retinal necrosis.
Good morning, everyone. Today I'm presenting a case of 32 years old male presented with blurred vision, periorbital pain and redness in the left eye, which he noticed after accidental splash of gunpowder during firing exercise. It was progressive in nature, associated with watering, photophobia and foreign body sensation. The slides are not changing.
Is there a slight changer there? You may be having a...
It was associated with watering, photophobia and foreign body sensation and floaters, not associated with flashes of light. Treatment history: initially he was treated as central and diagnosed as optic neuritis left eye in view of the disc edema. Treated with optic neuritis with intravitreal methylprednisolone 1 gram daily for 3 days, followed by tapering regime of oral steroids. However, there was no improvement in the symptoms. Subsequently evaluated at another center and diagnosed as pan-uveitis, treated with oral and topical steroids. 20 days later, patient presented at our center for further evaluation. Past medical history was within normal limits. Past surgical, no intervention was there. General examination was within normal limits. Ocular examination revealed distant visual acuity of 6/9 with no further improvement, and distant visual acuity left eye was 6/36 with no further improvement. Anterior segment examination of left eye revealed 1+ cells and flare. Fundus examination of the right eye revealed 2 tongue-shaped lesions seen in the peripheral retina, one in the superior-nasal and one in the inferior-nasal quadrant, with pale whitish yellowish black pigmentary changes, flat superficial lesions with well-defined margins and retinal vessels obscuring it. In left eye anterior, there was 3+ vitritis. Left eye fundus picture revealed whitish retinal lesions with present temporally, circumferentially, extending from 1 to 5 o'clock hours in width, extending from equator to the peripheral retina, having ill-defined margin obscuring retinal vessel with no associated retinal hemorrhages. Fundus autofluorescence right eye was hypoautofluorescent areas corresponding to the retinitis lesions, and the left eye revealed hyperautofluorescent areas corresponding to the retinitis lesions. Fundus autofluorescence of the both eyes showed patchy staining of the necrotic retina seen in all the phases. Same in the left eye. OCT macula of the left eye was within normal limits, no CME was noted. We took anterior chamber paracentesis was performed and aqueous analysis via multiplex PCR was done, which confirmed HSV2 infection. These are the other investigations. Factors favoring the diagnosis of acute retinal necrosis were immunocompetent status, bilateral peripheral tongue-shaped lesions. So we made the final diagnosis of HSV2 induced bilateral acute retinal necrosis, inactive in the right eye and active in the left eye. Oral valcyclovir 1 gram 3 times a day was given after checking urea and creat. Tablet prednisolone 1 milligram per kg was given and tablet ecosprin 75 milligram OD was started. After 1 week follow-up, the vision was hand movement close to face and PR accurate. On USG B scan, it revealed retinal detachment. So our plan was, so we did PPV with 240 band, FAX and 360 degree endo laser and oil insertion in the left eye. Post-operatively at day 7, the vision was 6/24. In the left eye, prophylactic barrage laser was done for the around the retinitis lesion in the right eye. Post-operatively, the patient's BCVA was 6/24 and healing of the retinitis lesion was noted after the antiviral treatment. So the take-home message is, any disc edema, especially with vitritis, always examine the peripheral retina with indirect ophthalmoscope. Thank you.
Well explained. So any questions? Yeah, it's very good. I'm just wondering whether anybody really needs to do a PCR because it's primarily a clinical diagnosis.
Yes, ma'am. Primarily, it's a clinical diagnosis, but for the documentation purposes,
Yeah,
we did the PCR.
that's fine. That's good. Similarly, fluorescent angiography is more for documentation. It's not
Yes,
required
ma'am.
for diagnosis. But I agree with you that in any case of uveitis, we have to dilate the patient fully, not even mid-dilate, and see the periphery carefully because it may give a clue to a lot of things. And this was very classical case.
Yes.
But why did you have to do a B scan to detect an RD when media was clear?
Just for the documentation purposes,
Again,
we
for the
have added.
documentation. Okay, that's good. Because otherwise you can see the RD
Yes, ma'am.
actually.
RD was visible, ma'am.
Yeah, so whenever we take a patient of acute retinal necrosis for treatment, we should tell them that even if we are able to treat your infection, you are always at risk for retinal detachment even few months down the line. Even when you recover good vision, the retinitis has healed, there is always a chance in these cases to develop a retinal hole down the line and develop a detachment suddenly. So they should be mentally prepared for surgery starting with the first visit and continuing throughout the other visits.
Yes, ma'am.
Because RD can happen suddenly during the course of the, and ARN can present in this, your case was very typical actually, but ARN can also present in many ways where it is anterior scleritis, severe pain, so we get distracted from this anterior picture and we don't even end up seeing the periphery, so, or the posterior segment. Sometimes the ARN can be mostly focused on the posterior pole, whereas classically it is described as peripheral retinitis. So if you just see posterior pole retinitis with disc edema, again ARN can be a possibility. It is described as, so atypical cases can be there and we have to keep our index of suspicion very high.
Yes.
Otherwise we burn our fingers and reach the diagnosis very late. But yours was a classic case. Also, I'm not very sure that you should be doing demarcation, laser demarcation prophylactically. There's a lot of controversy and it can actually create a vitreous traction and create breaks at the area of your laser scarring. But it's okay because it was a small area, not very large. If it's a large area, ideally you should avoid laser.
Yes.
The role of scleral buckle, ma'am?
Yeah, we can go into surgery, of course. But yeah, scleral buckle has a role, especially in ARN because the lesions are peripheral. So to support that, and the buckle also counteracts the future traction which is expected in these cases from the inflammation. So it's very useful. Buckle also reduces the silicone oil emulsification so that you are not forced to remove the oil early. So buckle does have a lot of role, supporting the brakes, reducing the traction and oil emulsification. And minimizing cryo in these cases is very important because that causes further thinning of the retina and inflammation increases. So you may use cryo, but it has to be minimized, more of laser rather than cryo. And use a longer acting silicone oil because we may have to keep the oil for longer in these patients. So use a 5000 centistokes oil which emulsifies later.
Yes.
It's readily available nowadays. So in these patients, ARN, CMV retinitis, we prefer to keep the oil longer because the disease may reactivate or breaks can form in the thinned retina down the line. And we also may like to keep them on steroids perioperatively, even post-operatively. So any other questions from the audience? We move to the next. Yes, please.
So if I encounter a patient who is PL negative in one eye, other eye has no evidence of AI, then what should be the dose of paracyclovir? Should it still be continuous or should it be at a lower dose?
Because it's a unilateral case?
So one eye is PL negative, there's no point of actually saving that eye, and the other eye has no lesion. So then should I go with the maximum
Prophylaxis you're talking about.
dose should be maximum, or shall I start with small?
I mean, I can't answer that with authenticity, but I guess you could just start with a maintenance dose, which is 1 gram TID for 6 weeks or something like that. Or you may not. I mean, you are going to target treatment for the PL negative eye also. You can't leave it inflamed.
Yes, but
So for that you need to treat properly. No.
negative, so probably
No, that's.
can I avoid complications of paracyclovir by starting with a
No,
lower dose?
Not only the vision,
Yeah.
there are other symptoms that need to be treated.
No, we
so
need
the-
to treat the inflammation even if it's PL negative. So we treat with full dose initially. When the inflammation comes down, only then we come to maintenance dose, and the maintenance dose continues. And valiocyclovir has hardly got many side effects. I have not seen anybody till now. And generally, we should have a physician with us when we are treating these patients so that they monitor for toxicity. But generally, it's a safe drug. All right, I think we go to the next case, otherwise we'll be short of time.
Thank you, ma'am.
Thank you, very good case.
So let me invite Dr. Sara Rizvi. Is she there? Dr. Vipin Rana? Yeah, he'll be presenting a case on rapidly progressive bilateral necrotizing retinitis in young Asian Indian male.
Good morning, everybody. Today I shall be presenting one of the rarest cases seen in the world. So, my patient was a 27-year-old male patient. He was soldier by profession and presented with complaints of diminution of vision in both eyes, which was rapidly progressive and was sudden in onset and painless, associated with redness, and there was no significant negative ocular history. So there was a history of febrile illness with swelling of the parotid glands for the 3 days before decrease in the vision. And he was treated conservatively with NSAIDs at another center and was presented to our center for further evaluation for ocular symptoms. So there was no significant personal and the family history, and general and systemic examination post this mumps infection was normal. So the ocular examination, the distant visual acuity best corrected in both eyes was counting finger close to face with accurate projection of rays, and in anterior segment there was flare 2+ in both the eyes. On fundus examination, this was a very classical picture, which it was a gyroid shaped cerebriform lesions, which were mainly perivenular and extending from disc through the fovea through the posterior pole to the mid periphery. The similar picture was seen in the left eye also. So the provisional diagnosis was mumps retinitis in view of the history of mumps present and the classical cerebriform lesion which is seen, which was described in the previous 4 case reports which have been reported in the literature since 2010. Fundus autofluorescence shows hyperautofluorescent areas which were corresponding to the these retinitis lesions, and the similar picture was seen in the left eye also. So the fundus fluorescent angiography showed mild hyperfluorescent areas which were corresponding to these retinitis lesion, and there was presence of this petalloid appearance also in the right as well as in the left eye. Similar findings in the left eye too. So ICG was essentially within normal limits, and the OCT showed the disruption of ELM and the ellipsoid zone in the right as well as in the left eye. On investigations, the serum IgG was for mumps was highly increased. Normal value is less than 4. It was 68.90, and IgM was more than 4. Normal is 0.9. So other investigations to rule out the other diagnoses, differential diagnoses, were negative. So, in view of these findings, the mumps-associated bilateral retinitis diagnosis was made, and the patient was already started on the oral prednisolone at Center A. So we added the oral val acyclovir 1 gram TDS, and in the literature, there are only 4 cases have been reported, and out of them, in one case, which was the last described case, hyperbaric oxygen therapy was given. So, I mean, as such, there is no therapy. So, we also thought of giving the hyperbaric oxygen therapy. So, it was given for 1 month, 2.5 atmospheric absolute, a session of 1 hour for 40 days. And to our surprise, post-hyperbaric oxygen therapy lesions resolved within 2 days. The lesions were same almost for the 10 days, but post-hyperbaric, they resolved within 2 days. However, the anatomical outcome was fine, but the functional outcome was poor. So OCT follow-up showed showed ellipsoid zone disruption and the foveal thinning in the right as well as in the left eye. And so in the literature, these are the 4 cases. The first was described by the LVPI in 2010, which showed it was in the retina diagnostic challenges. So why our case is unique? This is the first reported case in an adult patient. Only 4 cases reported, priorly that too in children. This is the first case where multimodal and ultraviolet field imaging has been carried out. And our case demonstrates rapid healing of retinitis lesion following hyperbaric oxygen therapy. Thank you.
Very good.
Thank you.
Etiology, basically, like, I have not understood.
Yeah, ma'am, there was a viral, if we see in the last 1 and 2 years, there was this outbreak of the mumps, ma'am. So he had a mumps infection, which we analyzed from where he catched up the infection. So the incubation period is 35 to 40 days. So he was in Nagpur at that time, and there was an outbreak of mumps. So he had other.
Can you show the fundus picture once? Why
Yeah.
could it not be ARN? Can you connect his computer again? His
Yeah.
presentation, yeah. Like, why is it not ARN and why is it mumps related?
Ma'am, ARN is absolutely in the like periphery, tongue-shaped lesions, and maybe associated with.
Can we see the fundus?
Yeah. This is the typical picture which has been described in the last 4 cases, ma'am. So the first case was described by from the LVPI. He was a faculty only doing a fellowship at that time, Dr. Trehan. So it was, yeah, ma'am, I'm coming to that. So it was there in diagnostic challenges in the Retina Journal. The second case was by Dr. Kalpana Babu. So the similar picture was there. And the third and fourth cases are from the Tunisia. So in fact, I had a word with with the authors from the Tunisia and with the Dr. Trehan also, ma'am. So this is a very classical picture of the mumps.
Very good, yeah. This does not look like ARN.
Yeah.
And this valacyclovir works for the mumps virus?
No, ma'am. Nothing works. Actually, nothing works. But in all the cases, I mean, valcyclovir was given. So, I mean, instead of giving nothing and just telling the patient you'll go blind, so we have to do something.
So it's an immunological phenomena rather than.
Ma'am,
viral
the theory which has given is direct invasion, immunological, or combined. It's just a speculation.
Steroids was added for this patient?
Steroid was added, ma'am.
Any role for intravitreal antiviral like anciclovir or foscarnet?
Nothing, ma'am.
Nobody has tried.
No. And all 4 cases were children. He was the first adult.
Very good, excellent. The documentation is also very good.
Thank you so much, ma'am.
Rare case. Yeah.
Yes.
Very nice.
Sure. Thank you so much, ma'am.
Very good.
So
There's no retina detachment described in this. So that's
We have seen, it's completely opposite. He can have some peripheral vision, like he can walk without support in his house.
So the previous cases, as madam has told, like down the line, is there a risk of retinal breaks and retinal detachment? The other cases which previously have been,
Nothing.
no.
Just like, atrophy is there, but there are no retinal breaks.
And pulse steroids was given and not.
Not in our case because it was given at some other center from where he
Yes,
was,
yes.
he was already starting.
Yes.
So the next case is presented by Dr. Swati Tyagi. Is she there? Yeah. So she'll be presenting a case on color of the human eye, a rare case of heterochromia iridis in siblings.
Good morning, everyone. My case presentation is color of the human eye, a rare case of heterochromia iridis in siblings. Waardenburg syndrome, having Mendelian inheritance in man number 193500, is a rare genetic condition determined by the absence of melanocytes from eyes, hair, and the skin, that is, the neural crest-derived tissues. The main clinical manifestations include facial anomalies, pigmentary defects, and hearing loss. There is an equal male to female ratio with no racial or genetic predilection. 4 subtypes with specific diagnostic criteria have been described. 5 major and 5 minor criteria have been established. The major criteria include congenital sensorineural hearing loss, affected first-degree relative, white forelock, dystopia canthorum, pigmentary disturbance of iris, including complete heterochromia, partial, or brilliant blue iridis. Minor criteria include synorphis, congenital leukoderma, hyperplasia of nasal alveoli, a broad nasal root, or premature graying of hair. The clinical diagnosis requires at least 2 major or 1 major and 2 minor criteria. Case description, we present a case of 2 siblings with difference in the eye color. Unilateral, diffuse pale blue eyes were seen, akin to a cat's. Dilated fundus examination of the affected eye revealed choroidal hypopigmentation. Sibling 1 had a sensorineural hearing loss in the left eye confirmed by audiometry. Telecanthus and synorphis were evident. There was no piebaldism. Dermatological and medicine evaluation revealed no anomalies, and there were no birth or family histories. In accordance with the diagnostic criteria proposed by Waardenburg, 4 major criteria were present, that is abnormal pigmentation of the iris, congenital sensorineural hearing loss, dystopia canthorum, and affected first-degree relative. 1 feature of the minor criteria was present, that is synorphis. Thus, both our patients were diagnosed with Waardenburg syndrome type 1. These are the clinical photographs. Both siblings had a unilateral brilliant blue iris, that is cat's eye appearance, dystopia canthorum, a broad nasal root, hyperplastic nasal alveoli, and synorphis. Fundus picture showed heterochromic fundi, that is areas of RPE without melanocytes were seen as non-pigmented, thus this appearance, and the choroidal vessels were prominent. Pure tone audiometry of the sibling 1 revealed a profound sensorineural hearing loss with a dead left ear, while the audiometry of the sibling 2 was within normal limits. Discussion, Waardenburg syndrome was first described by Dutch ophthalmologist Petrus Jonas Waardenburg in 1951. The reported incidence has been 1 in 40,000. However, it is under-recognized and on rise with the increase in consanguineous marriages. Oculocutaneous pigmentary anomalies are present. Diagnosis is essentially clinical. Not every case expresses all clinical manifestations. Forming-frustic conditions are relatively common. There is no definitive treatment. However, sensorineural hearing loss, bony anomalies, and Hirschsprung disease are potentially serious conditions which significantly deteriorate the quality of life. Genetics, Waardenburg syndrome has a full clinical spectrum wherein every case is unique in its features. It has an autosomal dominant inheritance with only a few de novo cases reported. It has an incomplete penetrance, and it is a genetically heterogeneous disorder. These are some of the previously reported cases in the literature. So the take-home message is that Waardenburg syndrome typically manifests with the congenital iris pigmentary anomalies. A careful inspection can reveal posterior uveal pigmentary anomalies. Its incidence has been under-recognized. The patients warrant complete systemic examination to rule out sinister complications. Importance of examination of all the family members to identify undiagnosed cases. Provision of genetic guidelines and medical monitoring of the affected family is pertinent. Regular ophthalmic examination is recommended to follow up any probable lesions. A higher index of suspicion aids in early diagnosis and thereby initiation of early treatment, social and vocational training, as well as rehabilitation of these patients. These are the references. Thank you very much.
It's an excellent case, very rare and beautifully documented. You said the inheritance is dominant. Autosomal dominant.
So there are 4 types of Waardenburg syndrome. The type 1 and type 2 are most common. They are autosomally dominant. Dystopia canthorum is present in type 1. Type 2 lacks dystopia canthorum. Type 3, which has upper limb anomalies like hypoplasia and syndactyly, those are rare and it is de novo. Type 4, which is Hirschsprung disease, is autosomally recessively inherited.
So in this patient, are the parents consanguineous? I mean, is it,
No,
in this
ma'am.
patient, what do you think is the
Ma'am, most
inheritance?
likely, since both of them had type 1, so it is an autosomal dominant. However, the parents did not have any symptoms.
No family history
ma'am.
of the same. And you said vocational rehabilitation. So what are the sequelae, ocular sequelae that they will require vocational or social rehab? What are the complications we expect down the line?
Ma'am, since there is I think it can lead to profound decrease in vision.
Why?
I guess.
Because what you have described is mainly cosmetic issues.
Yes, ma'am.
So, are there any known sequelae for which we should have to look out? You said they need annual checkups.
Yes,
For
ma'am.
what? Are we looking for some specific things, and why do they need vocational or social rehabilitation? What is the future down the line? What should we tell the patient?
So, ma'am, in case if they have a low vision, if there is any new de novo tumor in the eye,
So, they are at higher risk for
prone.
tumors? Is that what you're saying?
Yes, ma'am.
You haven't said that till now. Okay. What else?
And foveal hypoplasia you have mentioned?
Ma'am, in the present case, it was not there because the depigmentation was only in the periphery. However, in severe cases where the fundus finding is more towards the macula or the posterior pole, they can have foveal hypoplasia, and that can lead to a severe decrease in vision. So they might need low vision aids or vocational rehabilitation.
Tumors are only ocular tumors or systemic tumors?
Ma'am, so systemically, tumors have not been defined. Only Hertzsprung disease is there, but that is also congenital.
So we don't know what are the ocular sequelae of this problem, basically.
Yes, ma'am.
Except maybe foveal hypoplasia is an association,
Yes, ma'am.
which will be there by birth. It will not develop later on. So, okay. Very good.
Okay, thank
Good
you.
cases. Thank you.
Dr. Subhajit Chakravarti. Yeah. Dr. Malika Goyal will be presenting a case on large peripapillary choroidal granuloma.
Sorry, I should have kept it ready. I'm sorry. Okay, so I'll speak about a peripapillary granuloma in a immunocompetent young male, a 30-year-old male with a rapid vision drop in the left eye, uncertain amount of pain, not much, no other complaints or systemic diseases, no other relevant history, and the right eye was normal. The left eye showed a large peripapillary granuloma with RAPD. The anterior chamber was quiet, trace vitreous cells. There was a hemorrhages over the granuloma, some macular edema, and an inferior exudative retinal detachment. And the OCT through the granuloma showed the choroidal elevation. The B scan images were lost for some reason. So we had the diagnosis of nodular posterior scleritis, which was my first diagnosis because there was some pain, choroidal granuloma or lymphoma. So we investigated him for infections, the routine, most importantly TB, syphilis, HIV, and for the less common Lyme, rickettsia, leptospira, toxocara, and cat scratch. Autoimmune panel, sarcoid, SLE, and GPA or vaginas. And for malignancies, a whole body PET CT. For any other active inflammatory or malignant lesions, MRI brain was also normal, and a lumbar TAT for infections or malignancies. And we also did start him on IV steroid, pulsed steroid. In 2 days' time, the pain had resolved, and the vision had slightly improved from 2/60. But there was not much change in the granuloma height or in the lesion height. The TB-related tests were negative except the CT chest, which showed some evidence of past infection. So the pulmonologist was consulted and felt that he would benefit from ATT based on the chest CT. So which we made a diagnosis of presumed ocular tuberculoma. And why not sarcoid in this case, which is more common actually, but because it did not respond to the IV steroids the way we would have expected with sarcoid, and AS and calcium were normal. So he was started on the 4-drug ATT. He was also advised oral steroids with ATT, which he did not take. After a month, there was a rapid resolution of the, you see the choroidal elevation has gone, macular star has come in, vision is again normal, and at each test, each visit we tested the color vision because he was on ethambutol. So to be sure that we did not have a ethambutol toxicity. And a further 1 month later, even the macular star is near completely resolved. So this is 2 months from onset. And this is more lately, around I think 6 months from onset. Everything is normal. There is a scar where there was a granuloma and the macular star is resolved. A similar lady we are seeing more recently, very similar. And for her, Mantoux is positive. Again, chest CT is showing some changes and we have started her on ATT. So optic nerve tuberculoma is rare in an immunocompetent patient. And it's mainly a clinical diagnosis, though we do need corroborative evidence. Importance of multidisciplinary collaboration. In this case, we were able to start treatment based on the pulmonologist's recommendation of the CT scan. And in these patients, it's any case of uveitis, we start ATT. It's very important to continue to monitor them for ethambutol toxicity, which is more difficult because their vision is already compromised. So if there is one eye which is good vision, that eye should be monitored for vision as well. And color vision is very important, specific criteria for ethambutol toxicity. Every visit should be used to also test for ethambutol toxicity, and patient should be counseled that if there is a drop in vision, to stop the ethambutol. Now steroids are recommended with every patient who is on, who is considered as having ocular TB because of the inflammatory association. However, when we give steroid with ATT, we do not know whether the patient has responded to steroid or they have responded to ATT. So if possible, we should try to avoid steroids when we give ATT. As in this case, we did prescribe steroid, but patient did not take it. So we can be relatively confident that it was a tuberculoma that responded to ATT rather than to any steroid. Thank you.
Madam, was it even before initiating ATT, was he not put on oral steroids as you
He was put, yeah, that's a very good, that means you were paying very good attention to this. He was started on IV pulse steroids because we thought that even if it is TB, steroids are to be given anyway. And we didn't want to lose time because his vision was only 2/60, it is involving the optic nerve, so we didn't want to lose time. But yeah, unless we are sure there is infection, no infection, steroid could be counterproductive. You are right.
And coming to sarcoidosis, there is no bilaterality. There is only one optic nerve head granuloma.
Yeah,
so does the patient come into the diagnostic criteria of sarcoid?
Absolutely. Sarcoid is very often unilateral. Very often.
And
very
with no other symptoms in the body, in the systemic disease.
Yeah, so that's why we ruled it out, because serum AS was negative. There were no other systemic features. And more importantly for us, I think, because very often sarcoid also we never see systemic features. How often do we see?
Yes.
So the reason we ruled out sarcoid was there was no response to IV steroids. Now sarcoid should have melted away, absolutely. Right. Whereas there is no response. So that helped us to make the diagnosis of tuberculosis. And here the pulmonologist also felt that the chest CT was favoring tuberculosis.
Thank you, ma'am.
No, actually we wanted to continue oral steroids with the ATT. We had given him pulsed steroid, IV steroids, and then at discharge we wanted to give him oral with the ATT. But he did not take oral steroids because he could not tolerate it. So that way we had a 1 month of ATT without any steroid with complete resolution of the lesion, which gave us the idea that we are dealing probably with tuberculoma only. Yeah. Well, initially, I think we should try oral steroids only, because intravitreal steroid is an invasive procedure. It's also costly. It also causes more cataract and possibility of raised IOP. So oral steroid is much better. We can stop it whenever we want. It's so only when oral steroid is not working or patient cannot tolerate, then only we go to intravitreal steroid. Thank you. Yeah, I think we may run out of time. That's okay. One last question. One last. next presenter please come and get ready? Can you
Dr.
turn the next
Shamik
presenter?
Praful Mok. Yeah, please.
So we had given her full TB course till for almost 6 months. She improved and then she was lost. She again presented in 21 with a similar lesion in the other eye. So how do we go about it?
Okay, I got it. That's a very, see, it's a HIV co-infection.
Psoriasis.
Okay, so she's still immunosuppressed.
Yes.
So if she's immunosuppressed and she's incompletely treated, she disappeared.
Yes.
6 months of treatment maybe. So minimum is 9 months even in an immunocompetent person. And then in immunocompromised, it may be required for 12 months. And then we don't know whether it was a complete 4-drug or 2-drug or what was happening. She may not even have taken 6 months, we don't know. So if TB treatment is incomplete, patient is immunocompromised, we do expect recurrences. Even in an immunocompetent, we may have recurrences. ATT only reduces the incidence of relapses, but it does not completely eliminate relapses. So we may have to give ATT repeatedly in a person's lifetime. Even immunocompetent, but definitely immunocompromised. And then we are talking of incomplete treatment. So this is expected, actually I would say this is expected.
But then we continue again.
Absolutely, but this time we make sure she takes complete treatment, 4-drug ATT under observation, 9 to 12 months. That will reduce her risk of future recurrences but not eliminate the risk. Thank you.
Thank you, ma'am. Dr. Shamik will be presenting a rare case of Kawasaki disease with bilateral central retinal artery occlusion.
Good morning, everybody. I would like to thank the organizers for giving me this opportunity. I would be presenting a rare case of Kawasaki disease with bilateral central retinal artery occlusion. So Kawasaki disease is a systemic vasculitis affecting medium-sized arteries causing coronary aneurysms. Generally occurs in children less than 5 years of age. We report a case of bilateral retinal artery occlusion in young girl who was evaluated and diagnosed to have Kawasaki disease. So she was a 15-year-old girl, history of painless diminution of vision in both eyes in last 2 months. Best corrected acuity was counting finger at 2 meters in right eye and counting finger at 1 meter in left eye. Slit lamp biomicroscopy of anterior segment was unremarkable. On fundus examination, she had both eyes pallor of the disc, sclerosed arterioles, cherry red spot and multiple cottonwool spots. And OCT showed inner retinal hyperreflectivity, foveal thinning, cystoid spaces at fovea. So these were her systemic findings. She gave history of fever, generalized weakness since 2 months, oral ulcers, cervical lymphadenopathy, skin desquamation over palms and soles, multiple polymorphous and erythematous skin lesions on the back, and periungual peeling of skin of fingers. So these are the classic clinical criteria for diagnosis of Kawasaki disease: fever lasting for more than 7 days and presence of at least 4 principal features. These are the changes in extremities, acute, subacute, polymorphous exanthemes, bilateral bulbar conjunctival injection without exudates, changes in lips and oral cavity, and cervical lymphadenopathy. So the serology was positive for ANA, HLA-B38 and HLA-B40. Diagnosis of Kawasaki disease was established by the treating physicians, and she was started on oral prednisolone 50 mg per day followed by slow tapering. At 4 months, she developed neovascularization in both the eyes, and we treated her with PRP, but she went on progressing ahead to tractional retinal detachments in both the eyes, and she eventually lost vision in both her eyes. And we also couldn't follow her up because her mother had lost hope in her eyesight altogether. So Kawasaki disease is life-threatening with classical clinical features. Common ophthalmic signs are bilateral conjunctival injection and iridocyclitis. Bilateral conjunctival hyperemia is seen in more than 90% of children. Rare manifestations are retinal ischemia, ophthalmic artery occlusion, cranial nerve palsies, and papilledema. The presenting feature of bilateral non-purulent conjunctivitis is one of the criteria for diagnosis. of classic Kawasaki disease. This case is, however, was diagnosed in an adolescent patient with bilateral CRAO as the only ocular feature. Clinical suspicion of multi-system disorder must be borne in mind when young patients present with vascular occlusions. Thank you.
Excellent. Very rare case. And I think CRAO has not been reported anywhere except, in fact, I have not seen ophthalmic artery occlusion also reported. I've seen mostly ocular ischemia or,
Yes.
so in that way, I think this is the first, or am I wrong?
Ma'am, I tried to do a lot of search, but I couldn't find. But they have definitely mentioned that there could be presentation with central retinal artery.
Is it?
But in the classic criteria, they haven't mentioned it. In the classic
Yeah.
criteria, it's
Yeah,
still
so this
mentioned.
may be the first of its kind.
Madam, does this have any differential diagnosis, Behçet's?
Yes, ma'am. We thought of that as well, but she hardly had any hypopyon or iridocyclitis as such. She just had these.
No, but you don't need, but you don't need to have that.
Yes.
You
But
had oral ulcers.
oral ulcers were there, but then she had these other findings
Yes,
systemically,
yes.
which went more in favor of that,
Yes.
and also the serology, which was more in favor of Kawasaki.
What do you mean by that, serology?
The HLA-B38 and the ANA, which was positive.
Very good. And the HLA-B51 was negative?
Yes, ma'am. That was a complete HLA was done by the physician, and they were the ones who came out with the final diagnosis.
Yeah,
We
so if
just
it is
referred out.
Behçet's, you would have HLA-B51
B51
positive also.
positive,
Yeah.
So Kawasaki disease, can anyone here tell me like what it is? It is a disease of
Medium-sized artery.
medium-sized arteries, vasculitis. Yeah.
Vasculitis.
So if you
Thank
have
you.
a child, basically young person with bilateral CRAO, what would be the other things you would think of? Were there any inflammatory signs like vitreous cells?
Hardly any. There was very less vitritis, but then it was kind of mostly clear.
But there were some.
Very few. Just
Okay.
to name a few.
So in a bilateral CRAO, quickly just can we talk about the differentials? Here you had other features of Kawasaki. Now if you don't have any other features, one is Behçet's, what else? Young child, a 15-year-old?
15 years.
Yeah. So sarcoid,
Sarcoidosis.
SLE,
Vasculitis. Any of the
lymph
vasculitis.
leukemia,
Yes.
bilateral CRAO. Any bilateral vascular occlusion in a young person, leukemia,
Like
lymphoma,
hypercoagulable
any
states.
hypercoagulability, homocystinemia, antiphospholipid antibody.
But madam, those would
No, we are talking of having a
different
differential.
Okay.
Only
Yeah.
then you start discussing them. But you have to have a
Antithrombin 3.
differential with you.
Yes. Protein C, protein S deficiencies,
Yeah.
antithrombin 3, all those thrombophilic.
Thrombophilias,
Yes.
Leukemias, lymphomas, yeah. Good,
Thank you.
very good,
Thank
thank you.
So the next case will be, is Dr. Paulomi Datta there? Yeah, she'll be presenting case when not to operate, a lesson with traumatic cyclodialysis cleft.
Is Dr. Ananya there? No, so we just have one more presentation left, Dr. Anshika, right? Ananya is not there? Okay. So we'll be interested.
Good morning, everyone. I am presenting a case when not to operate, a lesson learned with traumatic cyclodialysis cleft. In this case, a 7-year-old boy referred from outside presented with the chief complaint of gradually progressive visible swelling over the white of his left eye for the last 6 months with mild redness in the left leg. On further history, he has a history of trauma with stone 3 years back, for which he has suffered limbal rupture from 3 to 5 o'clock, and which was repaired under general anesthesia, and previous documentation revealed a best corrected vision of HMCF in his left eye and 6/6 in the right eye. Sorry. On further examination, the right eye appears to be normal, but the left eye showing sluggishly reacting pupil and a large transluminant vascularized leg measuring 10 into 5 millimeter in size, extending circumferentially from 12 to 5 o'clock, encroaching into the temporal cornea, but the nasal cornea was clear, and anterior chamber was shallow, and lens was cataractous. And further examination, IOP was low, and central corneal thickness was high, and we could not do gonioscopy because of the encroachment of the swelling over the cornea, and dilated fundoscopy was also not done. So we have done ultrasonic biomicroscopy which has shown a gap, visible gap between the ciliary body and the scleral spur, and which was communicating with the suprachoroidal space, causing a traumatic cyclodialysis cleft. So we have planned conservative management with topical cycloplegic with atropine, 1% BD in the left eye, and UBM guided cryotherapy. And if no response, then surgical repair of the cleft along with lens extraction and IOL placement. But after 3 months of that, the size of the bleb started reducing, and by 6 months the bleb has completely resolved, and IOP being normal to 11 millimeter of mercury. And we have done the repeat ultrasonic biomicroscopy, and which has shown the spontaneous closure of the gap between the ciliary body and the scleral spur. The vision remained poor. So cyclodialysis cleft is a traumatic or iatrogenically induced pathway between the anterior chamber and the suprachoroidal space, which increases the uveoscleral outflow. There is no relationship between the cleft size and the degree of hypotony. So the first clue is the low IOP, and which was confirmed by gonioscopy, UBM or ASOCT, and managed by medical, laser or surgical technique. For small cleft, typically less than 4 o'clock, mainly the intervention is medical treatment with topical cycloplegics, often without steroid to promote scarring. And if no response, then treatment is transscleral diathermy or transconjunctival cryotherapy. And lastly, cycloplexy through the partial thickness limbal scleral flap. So as per published literature, these are some published literature regarding the minimally invasive technique in cyclodialysis cleft. So in conclusion, this is a rare case of which it has shown the dramatic resolution with a conservative treatment alone. Thank you.
Okay. So here we learnt about when not to operate. So can you tell me some indications where you can operate on such clefts?
If conservative treatment, after conservative treatment, it has not resolved, we have planned for the transcranial diathermy or surgical excision of the cyst along with cataractal lens extraction.
And some patch graft has to be done because
patch
that area
yes.
is thinned out already.
Yes.
Any questions from the audience? So post-operative hypotony, if the globe is intact, then one should think of cyclodialysis cleft. Post-trauma or post-surgical.
I'm completely, out of my depth here. I have no idea at all. So I'm asking as a novice, how do you diagnose a cyclodialysis cleft? And
at first, the child has presented with a swelling and with a history of trauma. So we have tried to do gonioscopy, and it was associated with the ocular hypotony. So we have tried to do gonioscopy, but the gonioscopy could not be done, and dilated fundoscopy also could not be done. We have thought of traumatic retinal detachment can also be done, can also be there. So we have tried to do USG B scan and UVM scan. So in USG there are no specific findings, but USG B scan we have seen there is a visible gap between the anterior chamber and the suprachoroidal space.
Yeah, just slides again. Can you please point it?
Yes.
you have a pointer?
Pointer.
No. You have a pointer there?
The image quality is very poor. Sorry.
It's still okay.
Pointer
There is
working?
Yeah, it's very fine.
this one.
Come here and show it with your finger maybe here, on the lower one. Okay. Gap between the CT and scleral. Okay.
And after conservative treatment,
So this is presented to you after how many days of trauma?
no, it may be iatrogenically induced also after
No, this patient presented
this
to
patient
you
patient with the trauma with the stone
how
three
many,
3
days?
years back.
3 years back.
3 years back.
Fine.
Okay. So UBM is important, is it?
Yes.
Okay, great. Thank you. Thank you very much.
Thank you, ma'am.
I think we have the last case now. Please go.
Dr. Anshika, yes, thank you. she'll be presenting on on a case, tuberculosis unmasked by unilateral solitary choroidal granuloma, a rare presenting feature.
It's not working. Good morning, everyone. I'm Dr. Anshika, and today I'll be presenting a case that presented to us with ocular tuberculosis. So this patient was a 24-year-old male patient with complaints of decreased vision with distortion of image for 15 days in his right eye. It was gradual and progressive. He did not have any history of trauma, floaters, pain or redness. There was no significant drug history, no history of any constitutional symptoms, difficulty in breathing, and he did not have any history of high-risk behavior. He had a family history in his father of TB who died because of TB-related complications around 8 years back. On examination, his BCVA in the right eye was 6/12 and in the left eye was 6/6. He did not have any RAPD. The pupil was round central, 3 mm, and normal direct and consensual reflex in both the eyes. On fundus examination, he had a single large subretinal round mass which was encroaching the fovea, and there was also some there was also associated significant disc edema in both his eyes. So you can see there was a single very large choroidal granuloma probably in his right eye. But what was unusual was a bilateral disc edema in this patient, which was symmetric. And this is a picture of the right fundus. Optic disc cube of both the eyes also showed an optic disc edema. And these were the OCT pictures of the same patient. This was the left eye. He did not have any changes in his macula. There was just an optic disc edema that was present in his left eye as well. So our differentials were papilledema, optic neuropathy, sarcoidosis, syphilis, and other infections such as toxoplasmosis, toxocariasis, vasculitis, multifocal choroiditis, and AMPPE. This was the visual field that was done to rule out any neurological fields. This patient, the initial battery of investigations that were ordered were CBC, Montu, and chest X-ray because we had a high suspicion of TB, followed by ESR. A neurologic consult was done, and MRI, brain, and orbit were also ordered, along with quantiferon TB, and then all the other differentials were to be ruled out, so we ordered further investigations. This patient had a positive Montu test. ESR was increased, chest X-ray was within normal limits, and MRI, brain, and orbit were unremarkable. His quantiferon TB gold was positive. So these were his MRI, brain, and orbit, which T1, T2, and flare sequence were done, which were completely unremarkable. So this patient was started on anti-tubercular therapy along with adjunctive oral steroid to mitigate the granulomatous inflammation, and we had a dramatic improvement. So this was a 4-week follow-up of this patient. We can see that there was a significant reduction in his granuloma, but the disc edema still persisted upon subsequent follow-ups as well. On 4 weeks follow-up, the exudative retinal detachment that was initially present was already in the resolving stage. The disc edema persisted for about 4 to 5 months in this patient, and even on we followed this patient every 2 weekly. Then finally, at 6 months followed up, we can see this fundus image, which is showing the resolving disc edema in this patient. And a guided progression analysis was also done, which shows 6-month reduction in the disc edema in this patient. So intraocular TB, it can have many presentations, most commonly presents as posterior uveitis. There have been multiple cases of optic neuropathy, and this was a case which we diagnosed as intraocular TB with the solitary choroidal granuloma in the right eye with bilateral papillitis. With bilateral papillitis usually have been reported only unilaterally in multiple cases. Bilateral presentation is quite rare. Only 10 to 15 case reports have been there so far, so because of lack of time, I'll just brush through this. There have only been 10 to 15 cases reported globally, which were bilateral tubercular papillitis. Most of them had also bilateral choroidal tubercles. This case had a unilateral choroidal tuberculoma with a bilateral papillitis because of it.
So any vasculitis that you have seen on angiogram, if not detected clinically, even that can be the reason why the patient had this papillitis?
Yes, ma'am, he did not have any signs of vasculitis
on clinical examination. But what on FFA you can still make out?
Ma'am, we did not do an FFA for this patient. We already had a very high clinical suspicion of ocular TB. So
no, I'm telling you that can be the reason for your optic neuritis bilateral.
Yes, ma'am.
Did you get what I'm telling you?
No.
Ma'am, do you agree? Or tuberculosis can itself present as optic neuritis, like in this?
Yeah, your question is with an optic disc edema, FFA would have helped.
FFA, because she said that there is no multifocality of the lesions in
Yes,
the
ma'am.
fundus, in both the fundus. Only one tubercular granuloma that has resulted in, that can result in disc edema in that particular eye. But the disc edema and congestion in the other eye, there are no other signs
Yeah, I agree.
of tuberculosis.
Yeah, that's right. I mean, yeah. See, vision was normal in the. To answer your question, whether I agree about vasculitis, see, most of the time we should be able to pick it up clinically with a dilated exam. So, probably I would not advise an FFA just to diagnose vasculitis, but if you're trying to document a case properly, yes. But for clinical management, probably if I don't see any signs of vasculitis, no cells, no vascular sheathing, no hemorrhages, probably I would not do it.
But the reason why the other optic disc is also
that part. So, you said the vision was normal in the other eye,
Yes, ma'am.
even color vision?
Yes, ma'am.
Yeah, so it's very, very unlikely to have optic neuritis with having normal vision, normal color vision, normal pupils. So, but it is there obviously in your case. So
Yes,
we
ma'am.
don't know maybe it's a tubercular bilateral papillitis. We have to accept it, but without any functional changes in the optic nerve.
Yes,
thing.
ma'am.
We have to accept it. Otherwise, I would have said, if it had not improved subsequently, I would have said it's pseudopapillodema, which is common in so many people.
Yes,
They have an appearance of disc elevation, but it's not really.
It has resolved actually.
But it
The
resolved.
follow-up.
But
Yes,
it did
ma'am.
resolve. So
Yes,
then
ma'am.
we have to just not think about that. But more importantly, let's come to some other things. Very well managed and very well treated. But how often is chest X-ray going to be useful and compared to CT chest? So nowadays, at least I have completely moved to CT chest because chest X-ray never gives any findings, whereas CT
Yes,
chest almost never not gives any findings. Always you get some sequelae of something or the other, some scar, some fibrotic lesion, some apical lesion is there, whereas chest X-ray never gives you anything.
Yes, ma'am.
So I think it's better to do chest CT as far as possible. Though the only downside is exposure, radiation exposure to the patient. That's a downside. But generally it gives some guideline, I would say. And you also had TB Gold positive,
Yes, ma'am. Quantiferin was positive.
which was very good. But you know, we don't even need these tests to be positive if we are clinically certain about our diagnosis.
Yes, ma'am.
Even in the absence of these tests, absence of any tests actually, we see repeatedly that if our clinical judgment is very strong for TB, there is no harm in giving an ATT trial,
Yes,
and most of the time it does work. But if you are trying to use it as an ATT trial, probably best not to give steroid at the same time, at least
Yes,
for 1
ma'am.
or 2 weeks. And in your case, it was not vision threatening; it was
Yes,
away
ma'am.
from the center. So possibly, so that we won't, otherwise we don't know whether steroid is working or ATT is working.
Yes, ma'am.
So if you're trying to do a therapeutic trial, probably it's better to withhold steroid if it's not vision threatening.
And these are very characteristic clinical signs of tuberculosis. So we
Yes,
can
ma'am.
still try with only ATT. There is not this is not an unusual finding.
Yes, ma'am.
So definitely, as Madam said, we can definitely go with a trial ATT,
Yes, ma'am. Ma'am, his ATT
Hello.
was started within 1 week of his presentation.
even
Was-
without steroids, oral steroids.
Yes, ma'am. We started the steroids a week after the ATT was started.
So now the recent evidence shows that only ATT can help. You don't need to put the patient on steroids at all. Like
Yes,
what
ma'am.
Madam's cases were previously, she didn't.
Yeah, every
use
case does
steroid.
not need steroid,
Yes,
frankly. Yeah.
Thank you.
Any other questions? We have only 5 more minutes left now. So any questions related to any cases? Yeah, please. Yeah, we are not one point is, see, we are not qualified to answer that question. But second thing is, why do you want to repeat? In our situation, in uveitis, we never need to repeat. We don't need to repeat. The physician may feel it's a requirement, but we never. We either have evidence of what we are looking for, or we don't have it. But we are not going to repeat that to manage our case.
Only like in the initial diagnostic workup, I think only once. Unless the patient has some acute pulmonary tuberculosis for which he is receiving ATT, probably we don't need to repeat.
ATT or sarcoid or whatever it is, nocardia or pneumocystis carinii, all these things may have pulmonary lesions, but we are not going to repeat them for us. So we are not qualified also to answer that question. Any other questions? Any other queries? So I think TB remains the number one thing which should be at the top of our mind whenever we are seeing a case of uveitis. Even if it looks like an autoimmune regular kind of uveitis, very often it's an immune response to latent TB elsewhere. So very often we have to fall back on giving ATT when there are repeated events of inflammation, not responding to alternative immunosuppression or to steroids even. So very often in my experience at least, we have had to give ATT to have a complete resolution in many cases. And we don't need to rely too much on Mantoux test, TB Gold or anything. Ultimately it's our clinical judgment, and when we refer a patient to a physician for ATT, they should fall in line and give the ATT if we want it. They should not say that we will not give because we are not having any evidence. Because clinical phenotype in the ocular of the ocular disease is enough indication. We don't need any more evidence to start ATT. So if your physician is refusing to give ATT, then you need to educate your physician that this is the current guidelines, that clinical phenotype is the most important indicator, and if we feel that it will respond to ATT, you should give ATT.
Now the TB program is going on. They are not much reluctant now.
Not much?
They are not much reluctant now to start on ATT.
Yeah. But we do have sometimes, even our own physicians, they do try to say that. Because they want to play safe, it is dangerous. ATT has a lot of side effects, not only optic neuropathy, which we see very often, but they have a lot of other problems in the body. So they don't want to get into trouble. And ethambutol toxicity is very common. Even in uveitis patients I've had where suddenly their vision dropped. And we might think it is because of uveitis, but actually it is ATT toxicity. So every visit of uveitis should also be used for monitoring for ethambutol toxicity.
Madam, do you think this is reversible? Like once stopping the drug, ethambutol toxicity,
Yeah. If it is stopped in time, definitely. And anyway, and we can add steroids, which helps the optic neuropathy reversal.
Thank you, Dr. Mallika. It was a wonderful session. I have learned quite a bit.
Thanks to everybody. I had a very good time. Thank you all the speakers, my panelists, and the society for the opportunity. Thank you very much.
Thank you.